A lot of fiscal conservatives in this audience, I would guess. Most of the conservative plans at the federal level would extend tax credits, refundable tax credits, to low-income individuals that aren't eligible for Medicaid today. How do you justify that to fiscal conservatives? And tell them a little bit about what you've proposed about I'm a rural hospital in Georgia. There's a federal law passed during the Reagan administration that basically says if someone comes into my emergency room in need of care, I have to see them and treat them even if they can't pay for that service. And so the hospitals, particularly in rural areas, maybe you're lucky to get 5 cents on the dollar. That's not really a free market. It's probably the biggest unfunded mandate in the history of our country. How do you fix that problem? And is it appropriate that we offer these refundable tax credits to these low-income citizens?
Sure. Well, 20 years ago, Jerry Musgrave and I wrote this book called Patient Power, and it greatly influenced the thinking of people like Newt Gingrich and Paul Ryan. And one of our main arguments was that the way we subsidize health insurance through the tax system is very, very wasteful. It's an unlimited tax benefit if you get insurance through an employer. And so the more money you spend, the more tax benefit you get. All of you can always lower your taxes by buying more health insurance. And that's a very wasteful way to subsidize health insurance. At the same time, we weren't doing anything for people who buy insurance on their own. And for low-income folks, they were either Medicaid or they were uninsured. So what we said is let's replace all of this, but we spend lots of federal dollars on the uninsured. So let's replace all of this with a refundable tax credit. Let's treat everybody the same way. I'm working on a bill with Pete Sessions right now, which I hope will be the House Republican leadership bill. And our tax credit is set at about what it costs to put people in Medicaid. And new people in Medicaid is about $2,500 for an adult, $8,000 for a family of 4. So that's the tax credit. So we would offer that to everybody. That's what you get, whether you get insurance at work, in the marketplace, or in exchange. That's what you get, and that's all that you get. Anything beyond that, you pay with after-tax, unsubsidized dollars. So that means that everyone would be able to have Medicaid-like insurance. If that's all you want to spend, that's it. But if you want more, you can have more, but you don't do it with somebody else's money. You and your employer do it with after-tax dollars. Now, we would make this universal. Everybody would have access to this. Now, but there will be people who will turn down that offer. There are people turning down Obamacare subsidies. I don't know if you all know this, but for every person in the exchange getting a subsidy, there are 2 more people who haven't enrolled, but who are eligible to do so. So I would hope with our system we'd be more successful in that. But in any event, what we propose to do is when people turn down the tax credit, you don't just put the money back in the Treasury. You send some portion of it to safety net institutions. So those are institutions that treat people who are uninsured and can't pay their medical bills. So money follows people. If everybody in Atlanta gets private insurance, then all the federal dollars are subsidizing that private insurance. Grady doesn't get anything. Okay? But if everybody in Atlanta decides to be uninsured, then all the money goes to the safety net, or some portion of the money goes to safety net institutions. But of course, you want to encourage people to go private because the care is going to be better, and they're going to add dollars of their own, so the system will have more money.
Something like that could really completely solve our rural hospital issue, could take care of Grady's issues, put everything on a fair playing field. On the other side of the aisle, there's going to be pushback and say, how do we know that these individuals are going to have good access to care? How do we make sure that compared to Medicaid expansion, how do we make sure they have access to care and good quality care?
Well, they will always have better care if they choose private insurance. And every study that's ever been done shows that private insurance does better than Medicaid. So we hope they choose the private insurance. Medicaid is not going to be as good, but that's our safety net. If they choose to be uninsured, there will be dollars there. And we can't ensure what the results are going to be. All we can do is say we're going to make a reasonable amount of money available. Local institutions are free to solve this problem. We hope they use their own intelligence and ingenuity to solve it in good ways. But you all know more about how to solve your problems than Washington does, so we don't want Washington to tell you how to do it, but we want to make sure that federal dollars are distributed in a fair way.
Let me just tell you, we originally were going to have Ken Thorpe with us. He's an economist at Emory. He served in the Clinton administration, and he and John actually agree on a lot of things. They're on different sides of the political spectrum, but in healthcare, there are a lot of things they agree on. I'm sorry Ken couldn't be here. He had to, at last minute, had to go to Washington today. But we've had some very good conversations. Part of that is what you've already addressed, is continuity of care. Let's keep people with their doctors, with their plan. You can change the way the subsidies are being provided. There are a lot of other areas. One is access to primary care. Ken is really concerned about chronic disease, and you've got to have access to a doctor. Just last year during this conference, we had in this chair Josh Umber, who has a direct primary care practice in Nebraska. He charges $50 a month, $600 a year, which includes about 25 office visits. You can call him up, text him on his phone after hours. What do you think about that? It seems like if we could even just spend $600 a person and get them access to quality care, that would be far better than what Medicaid provides.
Well, I like that. In fact, I've actually advocated for Medicare, but it could also work for Medicaid. But it would definitely work for Medicare. That the federal government consider paying part of the cost of a concierge doctor. Now, the traditional concierge doctor takes care of all primary care, and as you say, it's a fixed amount of money. Maybe we don't want the government to pay all of it, but maybe the government pays half of it, or for Medicaid patients, maybe it pays 3/4 of it. And then we are not in the business of fixing prices. The worst thing in Medicare and in Medicaid is government price fixing. Government drawing up a list of things it will pay for and everything on the list it won't pay for, and that makes it impossible for the private sector to innovate and find new ways of solving problems. With the concierge doctor, he has a fee, but you're not telling him what to do. You're not telling him what the fee is going to be for this service or that service. So he's free. Almost all concierge doctors talk to their patients by phone. They email their patients. Some of them are now using Skype. So they're free to take advantage of all the new technologies. And so sure, good idea.
One last question for me. Get your questions ready. You can write down your questions and hand them to the person with the microphones, and they'll ask the question if you're a little camera shy. Last question. You've written a lot about plan design changes, specifically deductibles and how we handle deductibles and what would be a better way. I think South Africa has been fairly innovative. Explain how we could change the way plans and deductibles work.
Well, I guess 20 years ago, I drew a diagram that looked like a pyramid. And at the base of the pyramid were all the small items, small costly services, and they would be paid from the health savings account. And then there was a gap that would be paid by the patient out of pocket. And then the top of the pyramid was all the expensive stuff, and that would be paid by third-party insurance. So I drew this pyramid for Congressman Bill Archer, who was head of the Ways and Means Committee. Well, he liked it so much he codified it, and I didn't anticipate this, but we got a law that said that if you want, then we called them medical savings accounts. If you want a medical savings account, your health plan has to look just like that. It has to have an across the board deductible, and below the deductible is a health savings account and some out-of-pocket costs, and above the deductible, insurance pays. And I mean, it was literally like that, and it limited the amount of exposure. It was the only health plan sold in the whole country where the government limited the amount of out-of-pocket exposure. You'd think that Obama would have loved it. But in any event, Bill Thomas came along and gave us the health savings accounts, but again, he codified this design. That's a huge mistake. We ought to let the market determine the design of the health savings account. And it just seems to me that common sense would tell you that there are certain services that we want patients to be completely in charge of and others that we don't. So if it's ordinary primary care and you're just doing, especially if we're doing controversial preventive medicine. Mammograms for healthy women is controversial. Prostate cancer tests for men, that's controversial. Most preventive most primary care tests are controversial. So what I mean by controversial is you see in the newspaper all the time, some people say you should do it and some people say you shouldn't. Let people make up their own mind. There's no reason for the third party to be paying for that. So those should all be paid from the health savings account. Forget the deductible, just from first dollar. In fact, I think patients could probably manage almost all of primary care. But let's say you have a test and now we have a finding of cancer. Once you have a finding of cancer, you don't want the patient to spend the next $2,000 or $3,000, however he or she wants to spend it. The plan has an interest in knowing and ensuring that cancer care is done in an effective way, high quality, low cost. So from $1, from that point on, the plan should be involved. So my argument was, let's just separate health care into those areas where patients can manage their own dollars and it's appropriate for them to manage their own dollars, from those areas where third-party involvement is wise and economical and from a medical point of view even necessary.
So if you have needed surgery, you're not going to face the $6,000 that a lot of the Obamacare policies have. That would be covered first dollar. If you have drugs to keep your heart disease under control, there would be no deductible. But if you went out and spent it on other things, the deductible would apply. Is that right?
Yes, or a better way to put it is, let's let the market solve this problem. The line between what decisions the patient should make and what decisions should be made by the third-party insurer should be determined in the marketplace and could change through time as we learn more about things. That's the key. We don't want to legislate what this plan has to look like. Let the market be free to choose the best design.
Let's open this up for questions from the audience. We've got about 12 minutes left. There are two people with microphones that are at both sides. Raise your hand if you have a question. And we can't see too well, so just start talking.
Thank you for all this thoughtful presentation. I'm wondering if either of you have thoughts on how Georgia could implement some of these ideas through what is now called ACA's 1332 state innovation waivers.
Well, I think that's the way you should think. The opportunity, I think, comes your way in 2017, is that right? And so any reform that you all are thinking about, it's going to take you to 2017 to get it implemented anyway. So that's exactly what you need to be thinking about. And that may be all the waiver you need. But if you need more, you need to think about what you need in order to do what you want to do in 2017.
Hi, good morning. I'm Janice Van Ness with Peachtree Academy Private School. And for 20 years, I was proud to offer insurance to all of my employees. And last year, I was told that I could no longer do that because I didn't meet the minimum requirements of 70% participation. Many people don't understand that you have to meet the 70% to offer it. We offered 28% of our employees participated in the program, and the rest were covered by their spouse's insurance. For that reason, we were forced to send our employees to the exchange where they weren't offered a better product. I was told that I couldn't incentivize or pay part of their health care coverage because that would be a violation too. And unless I rewarded every employee with the same amount, I would be unable to help them in any way whatsoever. So my question to you is, how do small businesses, I have over 100 employees, how do small businesses get around that? I've looked at MediShare, I've looked at other options, but it seems like there's no opportunities out there.
I fear for small business. I think it's going to be increasingly difficult. You know, a lot of employers are tempted to go to a defined contribution approach where you put up a certain number of dollars and let the employee go do what he wants to do. In fact, until recently, that was happening a lot. And although it seems to violate ERISA, in most states it was don't ask, don't tell. And so employers were doing it anyway. But what Obama has done, the Obama administration, is they've gone out of their way to keep you from doing that. And so if you put money into an employee's account and let them buy their own insurance, they're threatening to fine you $100 per employee per day. So they're very aggressively going against employers who want to empower their own employees. I think it's very, very difficult for a small business to be a health insurer. And therefore, I think all small businesses ought to be a defined contribution approach, if there's any reason to be involved at all. But if there is, it ought to be, insurance ought to be personal, it ought to be portable. Employees ought to have choices, they ought to take their health insurance with them. We ought to make it as easy as possible for the employer to act as administrator and get the small business out of the insurance market.
Can I just tell you one more thing? Yeah. So the real kicker is that I'm going to get penalized $2,000 to $3,000 per employee that I employ, even if they have insurance through their spouse, starting in 2016. So next year I'll be paying a $2,000 to $3,000 penalty, which many don't know. So thank you.
And that's crazy. There's no reason for that.
My name's David Johnson. I'm an anesthetist at Northside Hospital here in Atlanta. I have two questions for you, if that's okay. The first is, what do you think about using the federal government money to privatize the Medicare system here in Georgia? For instance, you are obviously a big proponent of health savings accounts. Coming up with relatively moderate deductible plans and then funding those plans with health savings accounts to cover the deductible. And then my second question is, here in the Atlanta market, I don't know about Dallas, hospitals seem to be becoming bigger and bigger. Recently, Northside is merging with Gwinnett Medical. Piedmont has merged, or was merging with Wellstar, that fell out. Emory's merging with St. Joseph's. So hospitals seems to almost becoming like airlines. How will that affect the way to reduce costs in the future?
Well, on the second point first, I'm very worried about hospital consolidation, and I'm worried about hospitals acquiring doctors, which they're doing at a rapid rate. And the Medicare payment formulas encourage hospitals to employ doctors because the hospital can bill twice what the doctor can bill for the same service. So it's almost, they're giving up a lot of money for the doctor to be an independent practitioner. And what happens when doctors work for hospitals, there's a case over in Florida right now where a whistleblower just revealed everything that's happening. Mainly hospitals exist to fill beds. The philosophy of most hospital administrators is our business model is we fill our beds. Therefore, what are our doctor employees supposed to be doing? Filling beds. And sometimes they're aggressively encouraged to fill beds. And that's what's happening over in Florida, that they're encouraging doctors to make decisions to put the patients in the bed, even when that wasn't always appropriate. So, and plus it gets anti-competitive. So we're putting more resources in the hands of an institution whose model of care is fill our beds, when it's perfectly obvious to the rest of us that we keep costs down by keeping people out of hospitals. I mentioned Integradet down in Houston. They pay their doctors more than what Medicare pays. And they pay them more because they want them to do things that traditional doctors don't do to keep patients out of hospitals. And if a patient actually does turn up in a hospital, they send their own hospitalist to that hospital to make sure that the problem is solved quickly, and then the patient gets out. The longer the patient stays in the hospital, it tends to be the worse things get. So I'm very worried about that, and I'm worried about the way the government is encouraging that kind of formation of the healthcare system. Now you said Medicare, but I think you meant Medicaid, using federal dollars to, yes, of course, that's what I'm talking about. We need to privatize Medicaid, but in a better way, and really open up to very different ways of doing this than the way we've done it in the past.
Yeah, my name's Al Ortel with Secure Health, and my question is, you're talking about innovation here, but are you not talking about privatizing Medicare with a corporation taking charge of that? What's your comment on going further with provider-sponsored plans and keeping the money local, whether it's local or regional here in the markets, and having the hospitals in Georgia combined with the physicians managing that care and keeping the dollars here?
Well, again, the one thing that Ken Thorpe and I agree most on, and Ken Thorpe, again, is the other health economists who couldn't be here today, but he advised Hillary Clinton. He's close to the Obama administration. So we are at different ends of the political spectrum. But one thing we agree on is that the one place in the United States where care is really being delivered in the best way, lowest cost, highest quality, is in these independent doctor association plans. That's where it's working. It doesn't work where you have some bureaucracy trying to tell the doctors what to do. It works when you have doctors associations where the doctors themselves meet regularly, and they have in these associations have a medical home, they have coordinated care, they have electronic communications so that if a patient's seeing 5 or 6 doctors, they all know what the other doctor is doing. They're getting quite good at that, and yes, that's how I want decisions to be made, not in the home office of Aetna or Cigna or United Health.
We got time for one more question.
We do about the bureaucratic aspect of both the government side as well as the private side. That seems the big hospitals and big companies can work it, but the smaller companies, like you were just talking about, the smaller businesses, the smaller doctors, don't have a way to work that system.
Well, unfortunately, the way our healthcare system works is what I call rent seeking. that basically the patient is not really involved. It's a war between the third-party payer institutions and the provider institutions. And once they agree on a contract, it's in the interest of the provider side to over-provide and to up the price by upcoding. And the payers are trying to, they have defenses against that. And an enormous amount of money is spent on both sides of that market trying to grab more of the dollars. So a great deal of what you're talking about exists only because of this third-party payment. The entity paying the bills is not the entity getting the service. In cosmetic surgery, you don't have all that paperwork, or in LASIK surgery and these other markets where third parties aren't involved. So part of the answer, though, is for Medicare and Medicaid, this contracting with the independent doctor associations, they really are only keeping the records that help them deliver care. And basically the third-party payers that contract with them, they are not interested in a lot of paperwork. They're interested in the bottom line. So there's a lot less bureaucracy. They still have to deal with Washington. But other than that, that seems to be a way within the third-party framework to reduce the paperwork.
John Goodman, thank you very much. We hope that we can continue to work with you and Ken to figure out a better way to provide innovative health care in Georgia. And we're going to take a 2-minute break. You do not want to miss this next presentation. We're going to reconvene in 2 minutes.